Okay, students, let's continue with part 2 of the cirrhosis. Let's resume the video.
Regarding the biliary tract, the extrahepatic biliary tract starts with the right and left hepatic ducts, and these join to form the common hepatic duct. The common hepatic duct is located anterolateral, or in front of and to the side of, the hepatic artery. As we move inferiorly, the common hepatic duct receives the cystic duct, which comes off the gallbladder, and it's at this point that the common bile duct, or CBD, is formed. The CBD continues inferiorly, passing behind the first part of the duodenum and along the posterior surface of the pancreas, where it joins the pancreatic duct. Together, the CBD and pancreatic duct drain into the second part of the duodenum via the ampulla of Vater and sphincter of Oddi. The gallbladder stores and concentrates bile during fasting and releases it into the duodenum to aid with the digestion of fatty food. The gallbladder is able to increase the concentration of bile through the absorption of water by the specialized cells that line its lumen. This concentrated bile leaves the gallbladder as a result of the actions of the vagus nerve and also cholecystokinin, or CCK, which is released by the epithelium of the duodenum. Both stimulation by the vagus nerve and CCK cause the gallbladder to contract and expel bile. The arterial supply to the gallbladder is from the cystic artery, which is typically a branch of the right hepatic artery. When we talk about the cystic artery, we have to think about an anatomical space called Callot's triangle, which was named after the French surgeon Jean-Francois Callot, who practiced in the late 19th and earliest 20th centuries. Callot originally described a triangular anatomical space that was formed by the cystic duct as the inferior border, the common hepatic duct as the medial border, and the cystic artery as its superior border. Interestingly, with the passage of time, our perception of Callot's original triangle has become slightly modified, and we now commonly assume the inferior border of the liver as being the superior component of the triangle, with the cystic artery running within this triangle. Now, whilst this isn't anatomically correct, and in keeping with what Callot originally described, the important thing to remember is that after coming off the right hepatic artery, the cystic artery traverses this space on its way to the gallbladder. And in the process, depending on whether you stick to the original definition or not, creates the superior border of Callot's triangle, or passes through the middle of the triangle. This means that when we operate on this area, for example during a laparoscopic cholecystectomy, if we can identify Callot's triangle, then we can aim to locate the cystic artery on its way to meeting the gallbladder. Therefore, we can be pretty confident that this structure that we plan to clip off and cut will not be something vital, such as the hepatic artery, common hepatic duct, or CBD, which obviously we'd want to avoid accidentally cutting at all costs. If you enjoyed watching this video, then make sure you subscribe to our YouTube channel for more great free content. Or, if you want to make sure you know what you need to know for med school, then subscribe to surgicalteaching.com for more great...
Thank you so much for your collaboration. Okay, so hepatocellular jaundice develops because the liver cells cannot effectively excrete bilirubin. This decreased excretion results in excessive circulating bilirubin levels. Intrahepatic obstructive jaundice results from edema, fibrosis, or scarring of the hepatic bile channels and bile ducts, which interferes with normal bile and bilirubin excretion. Patients with jaundice often report pruritus, which is itching. Hepatic encephalopathy, also called portal systemic encephalopathy is a complex cognitive syndrome that results from liver failure and cirrhosis. Patients report sleep disturbance, mood disturbance, mental status change, and speech problems early in this when this complication begins. Hepatic encephalopathy may be reversible with early intervention. So we have here in table 53.1 the stages of hepatic encephalopathy. In stage 1, there is emotional lability, impaired thinking, inability to concentrate, fatigue, drowsiness, slow speech, sleep pattern disturbances. So I want you to notice that from the very beginning of cirrhosis, stage 1, these signs and symptoms are already significant. Stage 2, disorientation to time, place, or person, asterisks, is the hand flapping. In stage 3, we have marked mental confusion, abnormal electroencephalogram tracing, muscle twitching, hyperreflexia. In stage 4, unresponsiveness leading to death, and most patients progress into this stage. And in these stages, there is no asterisks. There is a positive Babinski sign and seizures. So I want you to double check on asterisks to be familiarized, since this is a symptom that is going to appear in an early and on a first stage of the cirrhosis. See the hand flapping? You see, you notice that? We can see jaundice already, so this is probably a very advanced stage of cirrhosis. Okay, so that's asterisks. And the exact mechanism causing hepatic encephalopathy are not clearly understood, but probably are the result of shunting of portal venous blood into the central circulation, so the liver is bypassed. Elevated serum ammonia results from the inability of the liver to detoxify protein byproducts, and is common in patients with hepatic encephalopathy. Factors that may contribute to or worsen hepatic encephalopathy in patients with cirrhosis include high protein diet, infection, hypovolemia, decreased fluid volume, hypokalemia, constipation, GI bleeding, drugs, hypnotics, opioids, sedative, analgesics, diuretics, illicit drugs. Other complications: the development of hepatorenal syndrome indicates a poor prognosis for the patient with liver failure. This is often the cause of death in these patients, and the syndrome is manifested by a sudden decrease in urinary flow, less than 500 ml in 24 hours. That's oliguria. Elevated blood urea nitrogen and creatinine levels with abnormal decreased urine sodium secretion, increased urine osmolarity. Now, let's go. So does high urine osmolarity mean dehydration? Osmolarity increases when you are dehydrated and decreases when you have too much fluid in your blood. That's something that you need to understand. Hepatorenal syndrome often occurs after clinical deterioration from GI bleeding or the onset of hepatic encephalopathy. It may also complicate other liver diseases, including acute hepatitis and fulminant liver failure. Patients with cirrhosis and ascites may develop acute spontaneous bacterial peritonitis. Those who are particularly susceptible are patients with very advanced liver disease. The diagnosis of SBP, right, the spontaneous bacterial peritonitis, is made when a sample of acidic fluid is obtained by paracentesis for cells counts and culture. Another major complication of cirrhosis is hepatopulmonary syndrome caused by excessive ascitic volume. The client experienced dyspnea as a result for intra-abdominal pressure with limited thoracic expansion and diaphragmatic excursion. It means that the edema, the fluid, is going to avoid, it's not going to let the lung expand. This is, as I told you previously when we were discussing hiatal hernia, you know, each organ has its own space to expand, right? In this case, the fluid is not letting the lungs expand correctly. Etiology and genetic risk. The most common causes for cirrhosis in the United States are chronic alcoholism, chronic viral hepatitis, and bile duct disease. Hepatitis C is leading cause for cirrhosis and liver cancer in the United States. That's something that you need to know. Inflammation caused by infection over time leads to progressive scarring of the liver. We know that. It usually takes decades for cirrhosis to develop. Thanks God, it takes decades. Although alcohol use in combination with hepatitis C may speed the process. Common cause of cirrhosis: alcohol, liver disease, viral hepatitis, autoimmune hepatitis, steatohepatitis from fatty liver, drugs, chemical toxins, gallbladder, metabolic genetic causes, cardiovascular disease. Maybe it's time right now to speak about the metabolic syndrome. Metabolic syndrome is a concept that includes 5 medical conditions: abdominal obesity, high blood pressure, high blood sugar, high serum triglycerides, and low serum high density lipoproteins. So if you have 3 of this, right, which is your high blood sugar, you have abdominal obesity, high blood pressure, which is hypertension, high triglycerides, and low serum high density lipoprotein, you have your low happy cholesterol, then you're having metabolic syndrome. Okay, let's say you have the abdominal obesity, high blood pressure, and high triglycerides, let's say. You are already having a metabolic syndrome, and within time, you're going to develop multiple chronic conditions. This cirrhosis or hepatic conditions or fatty liver is one of them. Hepatitis B and hepatitis D are the most common causes of cirrhosis worldwide. Hepatitis B also causes inflammation and low-grade damage over decades that can ultimately lead to cirrhosis. Hepatitis D virus can infect the liver, but only in people who already have hepatitis B. So hepatitis D and B go together. Cirrhosis may also occur as a result of non-alcoholic fatty liver disease, a rapidly growing healthcare concern. NAFLD is associated with aging, obesity, diabetes mellitus type 2, and metabolic syndrome, which I already explained to you. Okay, it's called non-alcoholic fatty liver disease. This disease can progress to liver cancer, ring, cirrhosis, or failure, causing premature death. Up to 30% of Americans may have NAFLD. 30% of Americans. Because many people are not considering the fact that obesity is a leading cause of inflammation and is the leading cause of other conditions that can trigger cancer, right? The palatine-like phospholipase domain containing 3 gene PMPLA3 has been identified as a risk gene for the disease. Latinos have the gene more often than other ethnic groups and therefore are the highest risk for NAFLD. Another common cause of cirrhosis is excessive and prolonged alcohol use. We know that alcohol has a direct toxic effect on the hepatocytes and causes liver inflammation. The liver becomes enlarged with cellular degeneration and infiltration by fat leukocytes, lymphocytes. If alcohol is withheld The fatty infiltration and inflammation are reversible. I'm going to repeat that again. If alcohol is withheld, the fatty infiltration and inflammation are reversible. The long-term use of illicit drugs such as cocaine has similar effect on the liver. So if we withheld the alcohol and the fatty infiltration and inflammation are reversible, means that since we know that the liver is the only organ able to regenerate, means that if we lose weight and we lower the abdominal distension present in the obesity people, that is going to correct our triglycerides, is going to lower our blood pressure, and this condition is going to be reversible. The fatty liver is going to be treated and eventually is going to disappear. Incidence and prevalence. Approximately 3.2 million Americans have hepatitis C, and 1 in 7 Americans have hepatitis B, which can particularly affect Asian American and Pacific Islander born individuals. Combined, the incidence of chronic liver disease and cirrhosis is a major common cause of death in the United States. So let's see our assessment. Obtain data from patients with suspected cirrhosis, including age, gender, and employment history, especially history of exposure to alcohol, drugs, prescribed and illicit, use of herbal preparations, and clinical and chemical toxins. Determine whether there has been a needle stick injury. Sexual history and orientation may be important in determining an infection cause for liver disease, because men having sex with men are a high risk for hepatitis A, hepatitis B, and hepatitis C. People with hepatitis can develop cirrhosis. History of illicit drugs, history of tattoos, the patient has the patient been in military or in prison, is the patient a healthcare worker, firefighter, or police officer, right? We are in this group, and many things happen when we are working. We have accidents. We can by mistake have a needle injury. Ask the patient about previous medical conditions such as episode of jaundice, acute viral hepatitis, biliary tract disorder like cholecystitis, gallbladder, viral infection, surgery, blood transfusion, autoimmune disorders, obesity, altered lipid profile, heart failure, respiratory disorders, or liver injury. The physical assessment, we're going to find the patient in the early stage with fatigue, significant change in weight, GI symptoms, anorexia, vomiting, pain in the abdominal area, and liver tenderness. Okay, in the late stage cirrhosis, of course, we are going to have the jaundice and icterus, rashes, purpuric lesions as petechiae, brown pinpoint, red purple hemorrhagic lesions, or ecchymosis, warm and bright red palms of the hands, which is called palmar erythema, vascular lesions with a red center and radiated branches, spider angiomas, ascites, peripheral dependent edema of the extremities and sacrum, vital deficiency, especially your fat-soluble vitamins A, D, E, K. I know many doctors are not performing the mineral and vitamin checkup. That's something that you should check regularly or ask your primary care provider to order, right? Even if you are not in the gastroenterologist office, ask always your primary care to get an order for blood work related to your minerals and vitamins. It's very important. Abdominal assessment. Massive ascites can be deleted as a distended abdomen with bulgy flanks. Look, this is the ascites and the abdominal distension. Orthopnea and dyspnea from increased abdominal distension can interfere with lung expansion. We spoke about that. The patient may have difficulty maintaining an erect body posture, and problems with balance may affect walking. Of course, because the abdomen distension is pulling the spinal column, and the spine. So the spine is not having the normal shape and posture. So walking and balance is going to be in risk. Inspect and palpate for the presence of inguinal or umbilical hernias. Splenomegaly is common in non-alcoholic causes of cirrhosis. Observe vomitus and stool for blood. This may be indicated by frank block in the excrement or by a positive fecal occult blood. Gastritis, stomach ulceration, or oozing esophageal biases may be responsible for the blood in the stool. Amenorrhea is another symptom. No menstrual period may occur in women. Mental status, if the patient is unable to effectively communicate. Subtle changes in mental status and personality after progress to coma. A late complication of hepatic encephalopathy. Monitor for asterisks, a coarse tremor characterized by rapid, not rhythm extension and flexion in the wrists and fingers. We saw the video. Very important to know, hepatic encephalopathy, always monitor asterisks. Very important to know. Psychosocial assessment. Part of the psychosocial assessment is determining if the patient is alcohol dependent. Monitor for tremors, sometimes called the jitters, especially when alcohol withdrawal occurs after stopping alcohol. And you are going to see this very often in the hospital when a patient is admitted because of alcoholic use. And then after 6 of 8 hours of withheld alcohol, this patient is going to start having the jitters. Cognitive and neurologic changes associated with the little tremors may include acute confusion, anxiety, and psychotic behaviors. Laboratory assessment. Laboratory study. Abnormalities are common in patients with liver disease. Serum levels of aspartate and AST or ALT and lactate dehydrogenase typically are elevated because these enzymes are released into the blood during hepatic inflammation. So the three of them, AST, ALD, LT, and LDH. Okay. ALT levels are more specific to the liver. You see AL, the L of liver, whereas AST can be found in muscle, kidney, skin, brain, and heart. So that's something to remember. You can remember the ALT more related to the liver, AST to everything else. Increased alkaline phosphatase and gamma glutamyl transpeptidase, GGT. Levels are caused by biliary obstruction and therefore may increase in patients with cirrhosis. Alkaline phosphatase is a nonspecific bone, intestinal, and liver enzyme. Remember, phosphatase, phosphorus, bone, okay? Intestinal and liver enzyme. However, alkaline phosphatase also increases when bone disease such as osteoporosis is present. Total serum bilirubin also may be high. It's very important to know that the albumin, you need to monitor albumin when the patient presents with edema and ascites. Check your albumin levels, okay? Fecal urobilinogen concentration is decreased in patients with biliary tract obstructions. These patients have light or clay coral stools. Fecal urobilinogen concentration is decreased in patients with biliary tract obstruction. These patients have light or clay colored stools. Total serum albumin levels are decreasing in patients with severe or chronic liver disease. We mentioned that. Loss of osmotic pool, proteins such as albumin, because the albumin is a magneto to keep the fluid in the intravascular space. Proton beam time, international normalized PTINR is prolonged because of the liver disease, decreases the production of proton beam. The platelet count is low, resulting in characteristic thrombocytopenia or cirrhosis. So all these concepts we have already reviewed: the thrombocytopenia, the PTINR, we know about the albumin, anemia, because the hemoglobin of the and hematocrit values are going to be low. The white blood cells also may be decreased. Ammonia levels are usually elevated in patients with advanced liver disease. Serum creatinine may be elevated in patients with deteriorating kidney function. Delusional hyponatremia is because the sodium is low, right? So you have your assessment, more specific detail of your laboratory, right? So it's very important to remember that you're going to have elevated serum ammonia. We are going to have prolonged PT and prolonged INR. Very important to know. Imaging assessment. Plain x-rays of the abdomen may show hepatomegaly, splenomegaly, or massive ascites. A CT scan may be requested. MRI is another test used to diagnose a patient with liver disease. It can reveal mass lesion, giving abdominal specific information. So the liver ultrasound with Doppler. A Doppler ultrasound is a non-invasive test that can be used to estimate the blood flow through your blood vessels by bouncing high-frequency sound waves of circulating red blood cells. A regular ultrasound uses sound waves to produce images but cannot show blood flow. That's the difference. The ultrasound is usually the first assessment for this type of condition, and the liver ultrasound with Doppler is used for in detecting portal vein thrombosis. That's why they want to see how the blood is moving and evaluating whether the direction of portal blood flow is normal. Ultrasound transient elastography is a non-invasive test that measures liver stiffness, which helps the primary healthcare provider determine the amount of liver disease present. Some patients being assessed for liver disease require biopsies to determine the exact pathology and the extent of disease progression. These procedures can be problematic because of a large number of patients and a risk of bleeding. To minimize the risk, an interventional radiologist can perform a liver biopsy using a long sheet through a jugular vein that then is threaded into the hepatic vein and liver. A tissue sample is obtained for microscopic evaluation. The primary healthcare provider may require arteriography if US ultrasound is not conclusive in finding portal vein thrombosis. Also, we have esophagogastroduodenoscopy to directly visualize the upper GI tract to detect complications of liver failure. Endoscopic retrograde cholangiopancreatography uses the endoscope to inject contrast material via the sphincter of Oddi to view the biliary tract and allow for stone removals. Sphincterectomies, biopsies, and stent placement if required. So how are we going to manage the fluid volume? The interventions, supportive measures to control abdominal ascites include nutrition therapy, drug therapy, paracentesis, and respiratory support. The patient fluid and electrolyte balance is carefully monitored during the treatment. Nutrition. We have to provide the patient with a low sodium diet as an initial means of controlling fluid accumulation. 1 to 2 grams, 2000 sodium restriction may be tried first. Low sodium diets may be distasteful, so suggest alternative flavoring additives such as lemon, vinegar, parsley, oregano, and pepper. In general, patients with late-stage cirrhosis are malnourished and have multiple dietary deficiencies. IV vitamin supplements such as thiamine, folate, and multivitamin preparations are typically given because the liver cannot store vitamins. For patients with biliary cirrhosis, bile may not be available for fat-soluble vitamin transport and absorption. Oral vitamins are prescribed when IV fluid prescription is discontinued. Drug therapy, they are going to use diuretics to reduce the fluid accumulation and prevent cardiac and respiratory problems. Monitor the effect of diuretic therapy. You have to check the weight of the patient, check the electrolyte levels. Depending on the diuretics, select the provider may prescribe an oral or IV potassium supplement. Some clinicians prescribe furosemide or spironolactone as a combination diuretic therapy for the treatment of ascites. So we have to be knowledgeable about that these diuretics work differently. We have some that are used for maintenance of sodium and potassium. For example, furosemide causes potassium loss, whereas spironolactone conserves potassium in the body. All patients with ascites may have the potential to develop spontaneous bacterial peritonitis. Treatment involves IV cefotaxime and other third-generation cephalosporin or fluoroquinolones. Paracentesis. For some patients, abdominal paracentesis may be needed if ascites affects respiratory effort. A paracentesis is an invasive procedure performed to remove abdominal fluid. The patient having paracentesis, the most important things is ask the patient to void before the procedure to prevent injury of the bladder. Okay, so that's a very important factor to know. Document the characteristics of the collected fluid. After the catheter is removed, apply a dressing to the site, assess for leakage, common sense, take back vital signs and wait, right? Before and after the paracentesis. Respiratory support. He or she may develop hepatopulmonary syndrome. Dyspnea develops as a result of increased intra-abdominal pressure, which limits thoracic expansions. We know that. Crackles. So crackles are abnormal breath sounds that indicate the presence of airway obstruction or narrowing. They can be heard during auscultation of the lungs and can be classified as fine or coarse. Fine crackles are high-pitched and short and suggest left heart failure, interstitial lung disease, or pneumonia. Coarse crackles are louder, lower in pitch, and longer, and suggest pulmonary fibrosis or congestive heart failure. Auscultate lung every 4 to 8 hours for crackles that could indicate pulmonary complication depending on the patient's overall condition. Nursing safety alert for the patient with hepatopulmonary syndrome. Monitor his or her oxygen saturation with pulse oximetry. If needed, apply oxygen therapy to ease the breathing. This position, which is keeping the head of the bed elevated to at least 30 degrees, is going to improve breathing. Okay. This position with his or her feet elevated to decrease dependent ankle edema often relieves dyspnea. Remind assistive personnel to weigh the patient daily every morning before breakfast using the same scale. fluid and electrolytes balance are common. Blood, urea, nitrogen, serum protein, hematocrit, and electrolytes help determine fluid and electrolyte status. An elevated BUN, decreased serum protein, and increased hematocrit may indicate hypovolemia. So the expected outcomes is the patient is expected to be free of bleeding episodes, yes. And esophageal varices leads bleeding are the most common cause of GI bleeding. Interventions: all patients with cirrhosis should be screened for esophageal varices by endoscopy to detect them early before they bleed. Non-selective beta-blocking agents such as propranolol is usually described to prevent bleeding. Up to 20% of cirrhotic patients who are admitted to the hospital as a result of upper GI bleeding have bacterial infection. And even more patients develop healthcare-associated infection, usually cellulitis, UTI infections, or pneumonia. Infection is one of the most common indicators that patients will have an acute variceal bleed. Therefore, cirrhotic patients with GI bleeding should receive antibiotics when admitted to the hospital. Endoscopic therapies include ligation of the bleeding veins or scleropathy. Both procedures are very effective in controlling bleeding and improving patient survival rates. Esophageal varices may be managed with endoscopic variceal ligation. This procedure involves the application of a small O-band around the base of the varices to decrease their blood supplies. Endoscopic scleropathy, also called injection scleropathy, may be done to stop bleeding. These varices are injected with a sclerosing agent via catheter. This procedure is associated with complications as a mucosal alteration, which could result in further bleeding. The transjugular intrahepatic portal system shunt is a non-surgical procedure performed in interventional radiology departments. And I want to show you the video about how it's tips done.
Patients with portal hypertension may be asymptomatic or present with symptoms due to variceal bleeding, ascites, encephalopathy, or hypersplenism. Variceal hemorrhage can occur most commonly at the gastroesophageal junction and result in death. The TIPS procedure creates an artificial conduit from the portal to the systemic venous circulation to resolve portal hypertension and recurrent gastroesophageal varices. A small incision is made in the neck to access the internal jugular vein. A guide wire, followed by a sheath, is advanced into the internal jugular vein, ending in the right hepatic vein. A catheter is advanced over the wire into the hepatic vein. After the wire is removed, indirect pressure is measured using a balloon at the tip of the catheter. Once the catheter is removed, a long curved needle is placed through the sheath and thrust through the wall of the hepatic vein and adjacent parenchyma into a major branch of the portal vein. A portal venogram is performed via the needle to confirm proper placement. A wire is advanced through the needle. After the needle is removed, a pigtail catheter is advanced over the wire. The wire is removed. Direct pressure is measured in the portal vein to check for a significant gradient. The wire is placed back into the portal vein and the pigtail catheter is removed. A balloon catheter is used to dilate the tract between the hepatic and portal veins. The balloon catheter is removed and the sheath is advanced over the guide wire. The stent is advanced through the sheath until it is in proper position. at least 2 centimeters into the portal vein. The sheath is removed and the distal 2 centimeters of the stent in the portal vein expands. The ripcord is pulled slowly to open the stent. Portal vein pressure is checked to make sure it has lowered. Everything except the stent is removed. This stent routes the portal flow directly into the hepatic vein, bypassing the liver.
Thank you for your collaboration in this lecture. So there you go. You know how the transjugular intrahepatic portal systemic shunt is done. The intervention, we know that. Okay. And then collaborative interventions are planned around the management of slowing or stopping the accumulation of ammonia in the body to improve mental status and orientation. So because ammonia is formed in the GI tract by the action of bacteria on protein, non-surgical treatment measures to decrease ammonia production include dietary limitations and drug therapy to reduce bacterial breakdown. Patients with cirrhosis have increased nutritional requirements: high carbohydrate, moderate fat, and high protein foods. However, the diet may be changed for those who have elevated serum ammonia levels with sign of encephalopathy. Patients should have a moderate amount of protein and fat foods and simple carbohydrates. Strict protein restrictions are not required because patients need protein for healing. Drugs are used sparingly because they are difficult for the failing liver to metabolize. In particular, opioid, analgesic, sedative, and barbiturates should be restricted, especially for the patient with a history of encephalopathy. However, several types of drugs are eliminate or reduce ammonia levels in the body. These include lactulose or lactilol and non-absorbable antibiotics. The purpose is to obtain a laxative effect. Cleaning the bowels may rid the intestinal tract of the toxin that contribute to encephalopathy. And this is a very common practice in the hospital. Many patients are going to get lactulose. Observe for response to lactulose. Hypokalemia and dehydration may result from excessive stools. Remind assistive personnel to help the patient with skincare if patient to prevent breakdown caused by excessive stools. Because now you're having a patient getting therapy of lactulose. Now the patient is going to have massive stool or maybe diarrhea. Now the patient needs to have cleaning done very often, right? And if you don't do that, or if the patient get pressure ulcers because of this, you're in big trouble. Especially if they are elderly patients and they are not moving, turning and position every 2 hours, right? Which is the protocol. Frequently assess for changes in level of consciousness and orientation, just for asterix, which is the hands movement, and fetor hepaticus. These signs suggest worsening encephalopathy. Thiamine supplements and benzodiazepines may be needed if the patient is at risk for alcohol withdrawal. And we know that thiamine is vitamin B1. It's found in foods such as cereal, whole grains, meat, nuts, beans, peas. Thiamine is important in the breakdown of carbohydrates from food into products needed by the body. And benzodiazepines are depressants that produce sedation and hypnosis, relieve anxiety and muscle spasm, and reduce seizure. Examples are alprazolam, your Librium, your diazepam, lorazepam, well known as Ativan. Okay, how are we going to manage pruritus? This is a consequence of jaundice. Comfort measures include avoiding being too warm, moisturizing the skin and avoiding irritants to the skin. Some patients find that cool compresses or corticosteroid cream provide temporary relief. If these measures are not effective, drug therapy, including selective SSRIs, like sertraline, may be helpful. Now, you have to think about it. How many medications do we need to include to make this patient comfortable, right? So it's at the doctor's discretion and the nurse's best performance to take care of this. Home care management. He or her rest area needs to be close to the bathroom because diuretic and or lactulose therapy increases frequently. If the patient has difficulty reaching the toilet, use your commode. If necessary, check the mental status, shortness of breath, right? Position the patient in the bed with the head of the bed elevated in a semi-faller position to alleviate respiratory distress. And we have to provide all this information in terms of patient education, not only to the patient but the family, the diet, the restriction in sodium, to eat frequent meals, his or her nutritional intake or albumin, prealbumin is decreased after discharge. Multivitamin and oral nutritional supplements are usually needed. But you need to teach the patient to avoid excessive vitamins and minerals that can be toxic to the liver, such as your A-DEC, your vitamin A, vitamin D, vitamin E, and vitamin K, excessive iron supplements and niacin. We need to increase albumin by taking vitamins D and eating a well-balanced diet full of protein like lean meats, fish, nuts. Also, it's important to include niacin, which is vitamin B3, that helps keep your nervous system, digestive, and skin healthy. And B3 is present in cheese, milk, meat, tortillas, and cereal grains. It's very important to know your potassium-sparing medications, your aldactone, right? Your spironolactone, and your wasting diuretics, loop diuretics, such as furosemide, Lasix, anthiazide diuretics, such as hydrochlorothiazide, microside. Make sure to know your sodium and potassium levels so you have full control of this. Also, let the patient and the family members to recognize signs of encephalopathy and to contact the primary care provider. Reinforce that constipation, bleeding, and infection can increase the risk for encephalopathy. Avoid over-the-counter, especially NSAIDs, and hepatic toxic herbs, vitamins, and minerals. Right? Okay. Safety priority. One of the most important aspects of ongoing care for the patient with cirrhosis in health teaching about the need for the client to avoid acetaminophen, alcohol, smoking, and illicit drugs. And that's the end of cirrhosis.